The goal of the study is to understand the delay in intensification of treatment among patients with type 2 diabetes who are on metformin monotherapy. And this study was done in collaboration with Cleveland Clinic. The study is conducted using a database. So as you know, all healthcare system, and in this case Cleveland Clinic, has a database, the electronic medical record database, that was used to do a retrospective database analysis by certain parameters of defining patients who are on metformin, who are not at goal, that is their HbA1c was high at baseline, and to understand during the next period of time if they got an intensification or treatment or not. And we try to understand what are the factors associated with getting an intensification on time, and what is the impact of getting the intensification on time, specifically around achieving glycemic targets at a later time. Our main findings were that clinical inertia, which is often the term used to count for the delay in intensification of treatment, we found that it was relatively prevalent in this population, around 30 to 40%, and those who got intensified early were more likely to have achieved their glycemic targets during the follow-up period. So we also looked at this analysis stratified by different HbA1c targets as well as at baseline, stratified by the different baseline HbA1c, and found that patients who have higher HbA1c were more likely to intensify compared to those who were at lower HbA1c at baseline. I think the awareness that many patients who have diabetes are not controlled and perhaps can benefit from earlier intensification of treatment by appropriate intensification with additional drugs. In this particular study, many patients are on metformin monotherapy, as you know, were not at goal, but despite having inadequate time, there was no intervention done in order to intensify their treatment. Of course, there are limitations of the study. It's an observational data. We have to make certain assumptions around that there was no reason for the treatment to be intensified, not intensified in these patients. So that with those caveats, however, overall, being aware of this and trying to intensify treatment as appropriate early achieves glycemic goal targets, which is beneficial for patients with diabetes. The specific study was conducted among patients who are on metformin monotherapy only. So the results obviously are only generalizable to patients who are on metformin monotherapy. In concept, the idea is around when patient needs additional treatment that they should be intensified based on clinical guidelines. These are the guidelines that are suggested from ADA as well as the EASD consensus statements. I think metformin is a well-established first line of therapy. Patients who are diagnosed with diabetes are often started with metformin monotherapy. We wanted to understand what would it take for patients to get intensified with additional therapy after they're already on metformin. So that was the reason for focus on metformin monotherapy in this particular study. Not really. I would say we expected that patients often who are indicated by the guidelines to get additional treatment don't get intensified, and certainly there's a delay. Now this delay necessarily is not related to physician delay in acting. At times it could also be clinical inertia related to patient factors, such as patients not following adequately with the doctor's office, or they may not have access to the drugs, or any healthcare system factors that may also impact their ability to get the next level of treatment. I'm sure for individual patients there may be safety concerns around intensification of treatment, but at the level of the population, and again this is not related to being adequately controlled. These patients are on high HbA1c. Many patients were over 8 HbA1c percent. Our recommendation is to look at the different systems in the country and understand if there are many patients who have diabetes and have elevated HbA1c are not at goal, and then are they appropriate for further intensification. Further, we need to understand what is the impact of not intensifying treatment on longer term outcomes. As you know, and I mentioned before, that we only looked at the achievement of glycemic targets in a shorter term. but how that really impacts the longer term outcomes in terms of macro or microvascular complication, having not getting the intensification early is still unknown, and I think there should be more research. Another limitation is adherence to treatment. This particular study assumes that patients who are on the drugs were adherent to their treatment, which often is not the case. And it's also important to understand and put that into perspective from medication adherence. So we are doing some additional work to understand if these patients who are not at goal are not intensified, is mainly because they are not even taking their metformin in the first place.